Hello everyone, welcome back to the channel. In today's lesson we are going to talk about shoulder dislocation, one of the most common emergencies likely to encounter. Let's break it down as per definition, epidemiology, clinical features, management, and key points to note. Let's get started. Definition: shoulder dislocation is the displacement of the head of the humerus from the glenoid fossa of the scapula. It is the most common major joint dislocation encountered in emergency practice. Epidemiology: it is especially common in young active males. Shoulder dislocation accounts for more than 50% of all major joint dislocations. The anterior type is the most common, about 95%. Posterior dislocation makes up around 4%, and the inferior type, also called luxatio erecta, is rare. Types: there are three main types. 1. Anterior dislocation, the commonest. Subcoracoid, subglenoid, subclavicular, or even intrathoracic. 2. Posterior dislocation, often linked to epilepsy, electrocution, or trauma. 3. Inferior dislocation, or luxatio erecta, very rare, with the arm held overhead. The superior type rarely occurs. Predisposing factors. Predisposing factors include trauma such as a fall on an outstretched hand or a direct blow, ligamentous laxity, recurrent instability, and convulsions or electric shock, which often cause posterior dislocation. Clinical features. Patient presents with a history of trauma or a fall, sudden severe shoulder pain, and loss of function. On examination, the following will be seen. In anterior dislocation, loss of the rounded contour of the shoulder, giving the squared shoulder look. Note that this is the hallmark feature. The acromion is prominent, the arm is abducted and externally rotated, and the head of humerus is palpable beneath the clavicle or coracoid. In posterior dislocation, the arm is adducted and internally rotated, the patient cannot externally rotate, and the coracoid appears prominent. Don't forget to check for neurovascular injury. The axillary nerve is most commonly affected, leading to loss of sensation over the regimental badge area. Investigations to order for include the following. The main investigation is an X-ray of the shoulder, anterior, posterior, scapular Y, and axillary views. Always look at the position of the humeral head and check for associated fractures such as Bankart or Hill-Sachs lesions. Complications. Complications can be early or late. Early, neurovascular injury involving the axillary nerve, brachial plexus, or axillary artery, and fractures of the greater tuberosity or glenoid. Late, recurrent dislocations, stiffness, and osteoarthritis. Management. Management begins with emergency care. Give analgesics such as nonsteroidal anti-inflammatory drugs or opioids, immobilize the arm in a sling, and always assess neurovascular status. Reduction is done under sedation or general anesthesia. Techniques include Hippocratic method with traction counter-traction, Kocher's method with external rotation, adduction, and internal rotation, Stimson's method where the patient lies prone with the arm hanging and a weight attached, and also Milch or Spaso techniques. After reduction, confirm with an X-ray, immobilize in a sling or shoulder immobilizer for 2 to 3 weeks in adults or 1 to 2 weeks in the young. Then start physiotherapy. Surgery is indicated in irreducible dislocations, recurrent dislocations, associated fractures like those of the greater tuberosity or glenoid rim, and significant soft tissue injuries. Prevention of recurrence. Recurrence can be reduced by adequate immobilization after the first episode, proper physiotherapy focusing on rotator cuff and deltoid strengthening, and avoiding early return to contact sports. To recap key points as we conclude, the most common type is anterior shoulder dislocation. The nerve most often injured is the axillary nerve. Always do an X-ray before and after reduction. Recurrent dislocation is common in young males. And that's the end of our session on shoulder dislocation, explained in a clear style. If this video was helpful, make sure to like, subscribe, and share with your colleagues. Drop your questions in the comments, and I'll cover them in future lessons. Thanks for watching.